Good afternoon. It's a pleasure to be able to talk with you today about migraine in women. I have a lot of slides, but a lot of them are for your reference. I'm going to whip through a lot of them pretty quickly and try to linger a little longer on those that you might find very frequently in your general practice. So we'll start with an overview of migraine, just to review epidemiology, diagnosis, and treatment, and then hone in on why it is that migraine is so much more prevalent in women versus men, and go through some of the unique treatment opportunities in those women. In any one year, approximately 18% of women get migraine and 6% of men. And if you take a look at cumulative prevalence through a lifetime, it's more like 18% of men and over 40% of women. So I describe to my patients sometimes too, if they come to me and they're really having a lot of headaches, that it doesn't mean that they're always going to have headaches as bad as they have now. Sometimes you might just get a peak of migraine in the teen years and they go away, or maybe a peak and another peak. I don't know the natural course of that person's headache, but we kind of just manage them as they have them. This is an epidemiology curve, a prevalence curve for women versus men by age. So if you take a look at the top curve, that's women, the bottom curve is men, and if you start at the left side of the curve, you see that boys and girls, kids do get migraine. About 4% of kids get migraine, and boys and girls have an equal prevalence up to the time of puberty, when the graph takes off for women versus men with the disorder. And you see even after menopause that there's still a predominance of women versus men who get migraine. You also see in the shaded area, that's the peak prevalence, about 3 times as many women than men suffer with migraine. And that this is during the peak productive years when you're hit with these the hardest. Unlike other chronic conditions where you might be able to modify your lifestyle when you get these disabling episodes later in life, migraine occurs during the peak productive years when you're trying to juggle both kids and work and sometimes elderly parents. So if you can imagine unpredictable incapacitation 2-3 days out of the month, obviously it would really impact you. This is some headache art. You see a young woman who's laying in the bed. She's nauseous, she has a headache, she has a cold compress on her head. It's a nice day out, and again, she's missing a day of life. The kids are looking in to see whether mom's okay. So again, it hits during the peak productive years. If we take a look at diagnosis, just very broadly, we can divide it into 2 general categories when we look at headache. Primary headache disorders, for which we think it's probably a biochemical abnormality. There's no underlying structural abnormality. We kind of treat the symptoms. Or a secondary headache, what we used to call organic headache. Usually there's an underlying cause, structurally, metabolic, so you usually treat the underlying cause and generally the headache gets better. Things like brain tumor, aneurysm. We actually have a classification schema for the diagnosis of all kinds of headaches. We're up to the 3rd edition, beta version, and this year it'll come out with the final 3rd version. It's something to page through, not something to get bogged down in, but you can access it by the American Academy of Neurology on their website, just to take a look at how the different headaches are classified. It could help you as far as going through the differential. But if you take a look at migraine, these are some of the features of migraine by these classification schema. Generally, migraine, you have to have at least 2 out of the following 4 and 1 out of the following 2. About 60% of migraine are one-sided, which means 40% of the time they're bilateral. The quality of the pain is typically pulsating or throbbing in about 60%. So it can be pressure. Typically, it's moderate to severe in intensity. It's usually aggravated by exertion. That is, people usually kind of like to sit still or lay down. And you may get nausea or light or sound sensitivity. I mean, realistically, if you ever get a moderate to severe intensity headache, if there's ever throbbing, if there's ever light or sound sensitivity, chances are it's on the spectrum of migraine. And just from someone walking in your door for treatment, chances are it's migraine. Tension type is much more common, but people usually self-manage with tension type. Headaches may last anywhere from hours to days, 4 to 72, but in kids they last less than that, maybe only 2 hours. In menstrual migraine, it can last for a week or more. And there's even chronic migraine where you get a headache more days than not out of the month. Some people get them every day. There could be many phases to a migraine attack. Some people have a prodrome, which occurs hours or even a day before their headache. Some have dopaminergic symptoms, like they yawn a lot or they feel fatigued. Other people kind of do their best work right before a headache, almost like a hypomanic episode, or they have certain food cravings. Only about 1/3 of people with migraine get aura. Those are those focal neurologic symptoms. Most commonly, if you get aura, it's visual. They might get a slowly enlarging blind spot with a scintillation arc on the edge, what we call scintillating scotoma. People might get a zigzag lines, what we call fortification spectra, or even some weird symptoms like metamorphopsia, almost like an Alice in Wonderland, where everything spatially looks a little different to you. Approximately 11% of auras are sensory, where you get numbness on half of the body. Some people also get motor auras, where they get weakness or paralysis, hemiplegic migraine, but they're less common. Then patients will get the throbbing headache with the nausea, sometimes light sensitivity, and even after the headache is done, they're often left with fatigue or another day of a postdrome. As part of a comprehensive treatment approach, we always like to use non-pharmacologic measures, but probably the biggest piece in that is the patient educational piece, but it's also the most labor-intensive. So even if you know how to treat headache, not always that you have the time to go through everything that's necessary with the patient. But we also sometimes treat with abortive treatments, something you take PRN to get rid of a headache, or even sometimes daily preventive to try to cut down on the frequency and the intensity of the headache. When I review with patients the non-pharmacologic strategies, I kind of explain to them that they have a hyperexcitable brain, that you really want to do whatever you can to stabilize that brain, and that's kind of the foundation of the treatment. You want to get enough sleep, at least 7 hours. You want to stay regimented with your sleep cycle and your meal schedule. If you skip a meal, it can trigger a headache. Stay well hydrated, exercise a little every day. But also triggers, food triggers. If you can identify them, that's great. Not everybody has food triggers, but these are like your cheeses, your chocolates, your Chinese food, your processed soups, alcohol of any kind. And I feel strongly that patients, if they have significant headaches, should get off caffeine. Caffeine can actually help you during a headache, but if you take it regularly, it can actually keep that headache process going. Some patients also can benefit from stress reduction. You can't always change the stress in your life, but sometimes you can change the way that you handle it. Cognitive behavioral therapy, exercise, biofeedback, thermal EMG biofeedback. There's a lot of good stuff on YouTube too. It's not like they have to spend money on the biofeedback. Guided imagery or guided meditation on YouTube can be very effective. Physical modalities, including osteopathic manipulation, can work effectively for migraine. And in fact, there's some studies, these are just some studies that I picked out. There's more than this, but there are randomized studies with migraineurs specifically that have shown decreased disability by validated headache disability instruments. Also an interesting study, a retrospective chart review, taking a look at decreasing costs due to migraine, specifically for medications used when you do have OMT. The longer that I do headache, I do really respect that there's a cervicogenic trigger to many people with headache, especially for those that are really refractory to your medication treatment or those that exacerbate over time, and if they have significant neck issues. I often will refer for manipulation or for pain interventions such as injections or radiofrequency procedures. And I explain to patients that they have that hyperexcitable brain, but the more pain that goes up there, you lower the bar as far as triggering off more headaches. So whether it's coming from the neck, whether it's coming from the TMJ, whether it's coming from the sinus, whatever pain that we can access and decrease, we want to try to do. And that goes with the osteopathic concept, where the mode of operation is fundamentally the same, whether the somatic component is the primary or the secondary event. Treatment of the somatic component is accessible and is responsive to treatment, which establishes a more favorable balance of neural factors that improves restorative homeostatic mechanisms of the body. So getting into the drugs, usually by the time they come to you, you're probably going to send them home with at least an abortive therapy, something that they can take when they get a headache to get rid of it once it starts. And there's many patients that get milder headaches and they get more severe headaches. Rather than dissect it out, I found that if they get any headaches that are migraine type, probably all of them are on the spectrum of migraine. It doesn't really do me a whole lot of good to kind of try to dissect the tension versus the migraine. But if they can distinguish what kind of type of headache it's going to be, that this headache is going to stay mild, sometimes you can send them home with a lesser abortive treatment and then give them also something more severe for those more severe headaches. And every once in a while, you might get a patient where nothing works. It might happen once in a blue moon, and that's where the rescue medication comes in. At that point, you sacrifice functionality, you really just try to get them out of pain and save yourself a phone call, save them an ER visit, and that's what we call rescue medication. For other patients who get frequent headaches, or if the abortive therapies just don't work that effectively all the time, you might consider a daily preventive medication, and we'll go through that too. So when we look at treatments, we can again divide them into two general categories for abortive PRN meds. We have our nonspecific agents. They help for migraine. They also help if you stub your toe. For migraine-specific agents specifically work on serotonin 1B, 1D receptors in the brain. They're agonists there. They don't help for that stub your toe type of pain. Those are your ergots, DHE, and your triptan meds. But nonspecific agents, we have our over-the-counters, like acetaminophen, your aspirins, your NSAIDs, both over-the-counter and prescription, your combo drugs, such as the aspirin, Tylenol, caffeine, like Excedrin. We have our butalbital combos, which is a short-acting barbiturate that's often compounded with either acetaminophen or aspirin, plus or minus caffeine, plus or minus codeine. These are your Furosets, your Furanols, your Esgix, your Bupaps, and you have your isometheptane compounds, which are usually compounded with dichlorylphenazone and acetaminophen. These were your Midrin. It's also available in generic. Now it's available in another trade name called Nodalur. Narcotics can be used sometimes. Migraine-specific agents, before the 1990s, when Imitrex came out, all we had were the ergots, Cafergot, Ergostat, in a suppository or a sublingual. The problem with them is they're dirtier drugs. Not only do they hit the serotonin 1B, 1D receptors, but they also hit dopaminergic receptors. Often you need to use an antiemetic with it that's going to make people tired. So for the most part, ergot derivatives such as DHE, available in a sub-Q, IV, IM, and nasal spray, Migranol, and soon to come out a Medihaler, that we could use. But the triptans are really your go-to drugs for most people with headaches. Those are your serotonin 1B, 1D agonists. The next few slides you can keep for your reference, but just realize that if we're talking evidence-based therapy and the quality of the evidence base, I just want to share that with you. But all the triptans are level A, established effective. The antiemetics are level B, and the butalbital compounds are level C, possibly effective. So spending just a tiny bit of time on the triptans, since these are the ones that you're going to be using most commonly, we have 7 of them out there. They started in the 1990s and have worked our way up. Not a whole lot has come out other than different formulations over the last few years. But all of them are available in an oral form with at least a couple dosage levels. A couple are available in a convenience formulation that you can pop without water, such as Maxalt or Zomig. There's a couple available in a nasal spray, like Zomig or Imitrex. That's the sumatriptan nasal. There's another nasal spray coming out in like a powdered form with a novel device that you blow into. That's also nasal. That will be coming out soon. We also now have an iontophoretic patch where you slap it on and you push the button for a battery to get the medication through. That's sumatriptan. It's known as Acuity. That is available. And we also have a sub-Q, of which sumatriptan is still the only one available in sub-Q. We have generics. We also have a needleless stat dose called Sumavel Dose Pro. So we have a lot of variety. We also have a few that are compounded with NSAIDs, such as Trexamet, which is sumatriptan and naproxen. Pretty much you have a pretty high likelihood of success with any of them. So if you have to work with a prescription plan, it's probably worthwhile just going with what the prescription plan allows and kind of adjusting from there. The triptans as a class effect have some nuisance side effects, which generally don't alter your prescribing. Patients can still use them, but I do warn people that occasionally people might get a flushing or a tight squeezing in the chest or the jaw. If they do get that, it's usually mild. It usually passes within 15, 20 minutes. They don't have to stop because of that. But occasionally you get someone where it lasts longer, they get palpitations, or even it can intensify the headache rarely. And some people just don't want to use it if they get those side effects. But there have been serious side effects associated with the drugs too, because they do vasoconstrict. Even coronaries, they can vasoconstrict by 10 or 12%. So they're not indicated, they're contraindicated for people with ischemic heart disease or those with risk factors for heart disease. Also with uncontrolled hypertension. with certain rare forms of migraine like hemiplegic or basilar migraine, where people get bilateral neurologic symptoms or vertigo, not because they've been shown to be bad in that patient population, just because they haven't been studied. Although there have been a few case series that have shown that it works really well in that population, but as it is, the package insert says it's contraindicated. They're all pregnancy category C. Some headache specialists do use triptans during pregnancy. I don't, but if you had to use one, probably Imitrex, sumatriptan, has the most data in their pregnancy registry. The one thing that we could probably say is that if they inadvertently use a triptan early in pregnancy, that it's probably okay from what we know. And certain medications should not be combined. As it stands, you shouldn't use triptans, 2 different triptans within 24 hours of each other. There's also a precautionary statement about using other serotonergic drugs with triptans. But that's just a precaution. I mean, realistically, about 20% of people who are on triptans are also on SSRIs. So if there's a lot of serotonin syndrome out there, we're not seeing it. When to prescribe what? I mean, you're going to base your therapy depending on the intensity of their headache and the amount of disability that they suffer. You don't have to step them through lower-end treatments before you get to a triptan. You can go with the triptan first line. But you also want to know how rapidly the pain intensifies. Most of the time, migraine, they have a couple hours to play with the headache. However, there are some that within 15 minutes, they reach peak intensity of headache, or they have early nausea and vomiting, in which case you might want to use a non-oral formulation, which usually works quicker. You want to know what they've responded to in the past. If they've run through 5 oral triptans without success, using another one probably isn't going to help. In that case, I might just finish them off with the shot form of a sumatriptan and then kind of call it quits that they're non-responders. About 15% of people don't respond to triptans, so it doesn't mean they don't have migraine. And the other way around too, it's not pathognomonic that if you respond to a triptan that it's certainly migraine, because secondary headaches have also responded to triptans. When you get them back after you prescribe, whatever you prescribe, you want to assess how effective it is. And for some people, all they've tried is over the counter, so anything you give them looks better than what they've had. So you might want to ask, are you getting complete pain relief with your medication? Generally, they should be getting clinically meaningful pain relief within the first hour, and ideally be pain-free after 2 hours. Ideally, you want it to work consistently, not that half the time they're stuck. And ideally, you want them fully functional during that time. It doesn't take a whole lot of thought to prescribe an opioid, but if it's going to knock them out the rest of the day and they're still not functional, it's not ideal. You want to take a look at the side effect profile and also what the patient prefers. Some people prefer tablet over a melt form. Some people want the quick action of a shot, and also cost. Cost is a big issue. Even with the generic forms of the shots, sometimes they're still $80 if they had to pay out of pocket for them, and some of the triptans are $20. But every once in a while, on some of those GoodRx type .com websites, you can sometimes get a sumatriptan pill for $1.50. So for those patients that don't have a prescription plan. And then the rescue pain. For those times when nothing works, it happens, even with the triptan meds. What are your options? At that point, you sacrifice function. You just want to keep them out of the emergency room. So you might want to give an antiemetic, either in a pill or a suppository form, like a phenothiazine. You might want to give an opioid, either in a pill or even a nasal spray if they're nauseous, like a butorphanol Stadil nasal spray. You just have to be careful who you prescribe it to. And there's also NSAID, ketorolac available, again, in a nasal spray, the Sprix. If they have a prolonged headache, a course of steroids may also help break that cycle. So getting into the preventative therapies, what's our goal there? It's not a cure. If we can cut the number of headaches in half and make them more easily manageable, that's a realistic treatment goal. So they're still going to need abortive therapy. But these are the classes that we have available. None of the daily meds have been specifically developed for headache. They just so happen to work for headache, and we usually use lower dosages than what they're intended for. So there's actually only 4 that are FDA approved for the treatment of migraine for prevention, and those are 2 of the anti-epileptics, topiramate, Topamax, and divalproxodium, Depakote. And then we have 2 beta blockers, Blocadrin, which is Timolol, and Inderal, which is propranolol, although there's a few other beta blockers that have also been shown to help. There's a couple other classes of antihypertensives that have some evidence to suggest they help, such as an ARB, candesartan, or an ACE, lisinopril. The ones that have kind of gone down as far as the clinical evidence base is verapamil or other calcium channel blockers. The data just isn't as good. We also have antidepressants. The tricyclic antidepressants I still really like, although there's only a couple that are on the evidence-based chart, including amitriptyline, and possibly effective is protriptyline. I still like my nortriptyline, even though it's not up there in the evidence base. SNRIs can be used. The one that does have some evidence base is Effexor, venlafaxine. SSRIs, many patients are on them because the comorbidity of anxiety or depression with migraine, but they usually don't help headaches, not as well as the other drugs, and sometimes they can aggravate them, but sometimes we'll work with them because we're not going to achieve an antidepressant dose with the tricyclic antidepressants because of side effects. The triptans I'll get into in just a moment as far as short-term prevention for menstrual migraine. Triptan should not be used every single day throughout the month because they can cause medication overuse or rebound. Complementary therapies, things like vitamin B2, riboflavin, butterbar root, petacites, coenzyme Q10, feverfew, all of that magnesium have some basis of efficacy. But I'm not going to get into all of that today because of limits on time. And this you could just kind of sift through the next few slides as far as the evidence base again for prevention. I think one commentary, and I'm lifting some of the some quotes from review articles and from articles just because I wanted to say it, but they said it better. But although many preventives are rated as level C or U on the basis of quality of evidence available, for some treatments, extensive clinical experience supports a possible role in migraine prevention. And many older meds lack the financial justification for high-quality studies. Don't discount these older treatments until they can be accurately studied. In my opinion, a lot of the older drugs like amitriptyline or propranolol that have been around for decades, I think work just as well as some of the newer ones. And really you're going to base your therapy depending on their comorbidities for the most part. So, if they have some other medical problem, if you can hit the medical problem and the headache with the same med, that's wonderful. Obviously you try not to aggravate anything. And the only other thing that wasn't on there that you might be asking is Botox, where does that fit in? That's indicated for chronic migraine. It's not indicated for episodic. So for those people that get headaches at least half of the month, that's another treatment option. These are some of the comorbidities of migraine. Psych is a big one: anxiety, panic disorder, depression, bipolar disorder, fibromyalgia, insomnia, Raynaud's or other rheumatologic conditions. So again, for example, if you use a low dose of amitriptyline at night, might hit the fibromyalgia, might hit the neck pain, the insomnia, possibly even the irritable bowel, versus if they're bipolar, I probably wouldn't do that. So I think we gave an overview of migraine. Now, where does the women part come in? Let's take a look specifically of why it is that migraine is so much more prevalent, at least a threefold higher prevalence in women. It could be that maybe male brains are different than female brains. And I guess that's politically incorrect these days, but so be it. But all kidding aside, there have been even some recent studies, MRI and functional MRI studies, that have shown structural and functional differences in the brains of female migraineurs versus male migraineurs. Now, we don't know yet if there's a cause and effect and what the directionality of that cause-effect is, so there's a lot more research that needs to be done. But we do know that there's a lot of cycling of hormones and that certainly must play a part. You remember the epidemiology curve that once you hit menarche, the graph really takes off for women versus men with the disorder. So there must be something to it, and we know that neuroactive properties of sex steroids do seem to alter the threshold for women, for migraine in susceptible women. So it's not necessarily that your hormones are abnormal, it's just that your brain is hyperexcitable to the normal fluctuations of hormones. And we know that there's other medical conditions that can also be exacerbated throughout the menstrual cycle, including catamenial epilepsy, asthma, rheumatoid arthritis, irritable bowel, diabetes, just to name a few. This is a messy type of slide. There's a whole lot going on during the menstrual cycle, but if we take a quick look here, specifically at estrogen and progesterone, estrogen being the red solid line and progesterone being the yellow. And all the way starting at the left here, that's day 1 of the menstrual cycle, and the shaded area is menstrual period and the vulnerable time for menstrual migraine. You see that in the follicular phase, the first half of the menstrual cycle, you see a slow rise of estrogen up to the point of ovulation when you get that luteinizing hormone jump. You see a little dip of estrogen after ovulation, and then during the luteal phase, the second half of the menstrual cycle, again you see a rising concentration of estrogen, and now you also see a rising concentration of progesterone. Then you have that precipitous drop of both just before the menstrual period, and that's when it's most common to start with menstrual migraine. So what is it? Is it the estrogen or the progesterone or something else? Well, Somerville was a researcher who in the 1970s did see some of these classic experiments, and they are still cited today. It's not that I'm lazy as far as updating my references. Everybody always still cites him. But what he did is he took women with menstrual migraine and he injected them with estrogen a few days before they expected to get their period. And what this did is it shifted the time to the headache over to the right. So it delayed the menstrual migraine, but the period still occurred at the usual time. He did the same experiment injecting progesterone several days before the period, and what this did is didn't do anything for the timing of the menstrual migraine. That still occurred at the usual time. All he did was to shift the menstrual period occurred a little later. So the conclusion was that it's probably the estrogen and not the progesterone that does it. And we do know that there's widespread effect of estrogen, especially the withdrawal of estrogen, on all different neurotransmitter systems in the brain. It has an effect on neuronal cells, on receptor number and receptor function, and on migraine expression. Although the focus is on estrogen, there's probably other things that also play a part. For example, prostaglandins. And certain prostaglandins that occur during the menstrual period, when injected outside the menstrual period, can also trigger migraine. So it's probably not quite as simple as just estrogen. But these are some of the reproductive life events that can influence migraine. One of the peak incidents of migraine is menarche. About 60% of women note more frequent headaches over the menstrual period. Although most of them will also still get headaches outside of the menstrual period, only about 10% of migraineurs will get them only over the period and at no other time of the month. Pregnancy generally will improve migraine during the second and third trimester of pregnancy when you have a high stable level of estrogen. Probably about 3/4 of women improve. Perimenopause is a time of supraphysiologic fluctuations of hormones. So you get a lot of fluctuations, and sometimes the menstrual migraines can break down and you get more headaches. That's my biggest patient population, is perimenopausal women. But once you're through that, generally things improve during menopause. When you have that stable low level of estrogen, about 2/3 of women improve. Exogenous hormones have a variable effect, and I'll go through that in just a moment as far as oral contraceptives and hormone replacement therapy. Taking a look at menstrual-associated migraine, should we even distinguish menstrual migraine versus migraine? A migraine's a migraine, and I would agree. And most of the medications that we use for regular migraine outside the menstrual window also work for menstrual migraine. But there is a suggestion that menstrual migraines are more disabling, more intense, longer in duration, and just harder to treat overall. And in the clinical trials, there's actually some slightly lower response rates and higher recurrence rates when you treat the menstrual versus non-menstrual. But we use the standard abortive treatment during the menstrual migraine, but you might want to consider relaxing conventional limits of abortive treatment. Usually we tell people, because we're afraid of giving them rebound headaches, not to use their abortive more than 2 days out of the week. But if the only time they get their headache is that week of the menstrual period, even if they get it 3, 4, 5 days, I'm okay with them using the abortive that frequently. You run a low risk of rebound headaches if that's the only time that they're going to do that. You might want to consider medications with lower recurrence rates. I mean, any of the triptans, about 1/3 of the time, patients will get their headaches back within a 24-hour period. So that's a problem with all of them. Some of them do have lower recurrence rates, but you also still want that initial efficacy. You want to stress early intervention. Like if they know, look, this is going to be the menstrual headache, jump on it early. You might not tell them to do that for every headache, but over that time, the earlier you treat, usually the more effective it's going to be. You might also want to consider non-oral formulations. Sometimes even if they don't have the nausea and the vomiting, they do have gastroparesis, and maybe they're not absorbing the pills all that well if they're not getting great relief. And consider rescue medication for those times when the menstrual migraine becomes out of control. One unique treatment opportunity for those women who get regular menstrual periods and regular headaches. Easier said than done. It's not an exact science, but if they can predict when they're going to get their headache within a couple days, sometimes you could target that vulnerable time and start an NSAID or a triptan a good 24 hours before they expect to get their headache and follow it through the vulnerable time as a preventative. So you might give them that for 5 or 7 days, depending on how they can target it. And it might prevent that menstrual migraine from occurring. There have been some studies that have shown benefit with naproxen sodium done this way, with mefenamic acid, which is meclamin, or Relafin. But what they did in the clinical trials, they usually used it for 2 weeks at a time, which is kind of long. We would like to target it a little narrower. But triptans have also been used, and many of them have been shown to be somewhat effective. When considering the use of short-term mini prophylaxis, sumatriptan, zolmitriptan, naratriptan, and frovatriptan have shown efficacy. However, frovatriptan appears to be the triptan of choice based on overall efficacy. It has the greatest level of evidence base, but I don't use it all that frequently to target over that menstrual window because I usually find that triptans work fine on a PRN basis. Why expose them to 7 days of a triptan if you're going to get good relief that way? Even if they get multiple recurrences, usually they'll still get relief if you redose for recurrence. The FDA has not approved specifically for menstrual migraine prophylaxis for any of the triptans. There was a little bit of an uptick in headaches, once that triptan stopped. So therefore, they figure maybe it's basically just delaying the menstrual migraine. But it is a treatment option. Daily preventatives can be used, just like we discussed before, like your Topomex, your Depakote, your Indirel. Even if they just get that menstrual migraine, if it's particularly hard to treat, if they're disabled for a couple days and just nothing works, you might still want to give them a full course of monthly prevention. But hormonal manipulation is another option. Probably the OB-GYNs are more likely to reach for that earlier than the headache specialists. We might run through, the short-term prevention first, but it is an option. Basically the goal would be to stabilize estrogen levels. You want to suppress ovulation, and you want to try to prevent that drop of estrogen. It seems it's the magnitude of the drop, that if you drop more than 10 micrograms of estradiol during that time, then that may be enough to trigger off a headache. So with estrogen supplementation over the menstrual period, it has been shown that the patch or transdermal seems to be the best approach. And if you do an estradiol patch, the minimal effective dose seems to be 100 micrograms because you need at least that much to kind of maintain no more than a 10 microgram drop. They've also tried estradiol percutaneous gel, and the minimal effective dose seems to be 1.5 milligrams topically. So that's an option. I don't do that really all that often. I'd probably do more so extended cycling of oral contraceptive pills. Just to try to suppress ovulation. It's probably more likely to suppress ovulation and just kind of keep a lower dose of estrogen that's more stable. So combined hormonal contraceptive use. There's always that question, can I use it or can't I use it? Well, there's no clear relationship between headache and OC use for most women. You can't predict who's going to worsen or who's going to improve in it, and it may not happen right away. So even if you say, okay, well, maybe your pill is causing your headache, you stop for a month, and then the headache's still there. Sometimes it could take 2 or 3 months to get a change, once you're on that, and you can't predict who that's going to happen to. And maybe the case is why it doesn't help as frequently as it should is that ovarian function is not always entirely suppressed, and hormonal fluctuation may still occur. You might still get that fluctuating estrogen level. You don't need to suppress ovulation to get that birth control effect. So, and even with the low-dose pills. But it's suggested that an extended dosing of oral contraceptive probably is more likely to suppress ovulation. Can you use combined hormonal contraceptives? These are the ones that contain estrogen and progestin. Well, current recommendations by ACOG in 2006, which still stand today, is that you really should not use them if anybody gets migraine with aura. It seems to be those migraineurs with aura that have increased ischemic stroke risk in young women, so not to use them. You can use them in migraine without aura as long as they're under the age of 35. If they're over the age of 35, regardless of if you have aura or not, it's recommended not to use an estrogen-containing pill. And certainly don't use it if they have other risk factors for stroke, like smoking. But there is the relationship between stroke, migraine, and combined hormonal contraceptive use is complex and controversial. There's a lot of buzz, especially in the headache world, that a lot of these guidelines, they were based on pooled data that were old data, even when we had higher dose pills. And almost all of those ischemic events occurred on the higher dose pills. Also, there were some European studies with that. There were higher amounts of smokers in that study. So some people don't believe that there's a higher risk of stroke with the lower dose pills that we use today. When it comes to migraine with aura, we do know that the higher the estrogen, the higher the likelihood of aura. And the higher or greater number of auras that you have, the higher your likelihood of stroke. So we don't know about the converse, that if you can suppress auras by keeping a low estrogen level, perhaps you could decrease stroke risk in those people with migraine with aura. We're not sure. But there is newer data. Ann Calhoun is a headache specialist, a colleague of mine, that did some great review articles looking at the pills and what they actually do. What she did is, there was a retrospective review that they did of very ultra-low dose estrogen. The intravaginal ring, the Nuva ring, has 15 micrograms of estradiol, and they did extended cycling. And actually, over 90% of the headaches, the menstrual migraines, were prevented by this extended low-dose regimen. And also, there was a lower likelihood of aura. It went from 3.23 auras in a month for the mean down to 0.23. So the question is, could this be a good thing if we can suppress estrogen levels and actually have lower estrogen levels than what's in the native menstrual cycle? Your other option is progesterone-only birth control, whether it be the pill, whether it be the shot, the Depo-Provera, or whether it be the implantable. But historically, the progestin-only agents have been less well tolerated because of breakthrough bleeding and some higher pregnancy rates. Taking a look at pregnancy and migraine, some of the issues, pregnancy is a pathologic state. It's a hypercoagulable state. You run a greater risk of stroke with pregnancy than with any birth control pill. So that's just a consideration too, with whether or not you're going to prescribe a pill. But there's a higher likelihood of secondary headaches such as cerebral venous thrombosis, other strokes, subarachnoid hemorrhage, preeclampsia and eclampsia even after delivery, and also low pressure headaches after spinal anesthesia. Approximately 1 to 5% of the time, there's an unintended dural puncture with the spinal anesthesia. And a recent study taking a look at headache in that patient population, about 75% of women actually developed headache if they had vaginal delivery. 11% developed it with C-section, probably because of the pushing, opening the tear even more as far as the low pressure leak. But even 6 weeks down the line, over a quarter of those women still had headaches at that time, so it might be a consideration. Most people do improve during pregnancy, during the second and third trimester, when you have the high stable level of estrogen, but usually people will get their headaches back shortly after delivery. Nursing does seem to have some protective effect, at least temporarily. We were always taught that migraine doesn't mean that you have a higher complication rate during pregnancy, but there's some new data that will be presented at the American Academy of Neurology by Matt Robbins at Montefiore this month. And what they found is that, it was concerning that they looked at 90 women who presented to the emergency room who were pregnant and who had severe migraine. And there was a higher likelihood of preterm delivery, preeclampsia, and low birth weight. In fact, over 50% of these women who came with severe headache to an emergency room setting ended up with some adverse birth outcome, with 30% preterm delivery, 20% preeclampsia, and if these women were over the age of 35, they were 7 times more likely to have these complications. So there's some question whether or not there might be a risk with migraine. Not all medications obviously used for a non-pregnant migraineur should be used during pregnancy. And I always keep looking everything up, and nothing is 100%. Usually we're taught, put a simple analgesic on board, plus or minus caffeine. Don't use the NSAID after the second trimester. Reglan or metoclopramide is category B. However, nothing's 100%. There were some recent studies that have called into question even the safety of some of these simple analgesics. FDA reviewed them, did not change their guidelines, but do have a precautionary statement. The study showed NSAIDs had increased miscarriage when used in the first half of the pregnancy, risk of birth defects when using opioids in the first trimester, and even acetaminophen possibly being related to ADHD in the kids when used at any trimester. So there's always that precautionary statement. Menopause, there's a higher likelihood of increased frequency headaches and increased intensity headaches around perimenopause when you have that high fluctuating levels, that irregular menstrual periods, sometimes heavy flow, possibly increasing prostaglandin levels produced by the uterus. But once you make it through menopause, 2/3 of women improve. I do still have some older women that continue with headaches, but that's unusual. Unfortunately, if you have surgical menopause, whether or not they take the ovaries, generally 2/3 of women worsen. So that's not a form of treatment for menstrual migraine. Hormone replacement therapy is not a contraindication as we know it now, but there is some question whether or not it may also increase stroke risk, especially in those women who do get ARA. But you can use it. If you do use it, it's recommended that you use the lowest effective dose, that you use continuous versus cyclic therapy, and that you use the patch form versus the oral, just for a more stable level of estrogen. But in the women's health study, they actually found about a 1.6-fold uptick in women migraineurs who used hormone replacement therapy as far as headaches. So there might be something that you may not want to use it. So I think we covered the overview of migraine, the diagnosis, the treatment. I think we covered some of the issues specifically in women as far as the reproductive hormonal events and their influence on headache. But I think it's also important to note that there's other influences, not just hormonal, and we should look at kind of the whole picture, not just the hormones. As far as medical marijuana, I mean, some people say they get some relief and there's something to the cannabinoid receptors, but even in a recent review, there's still a lot of question marks about that. As far as topical products, whatever helps. I mean, some people like to sit in a warm tub with an ice pack on their head, or they like a heating pad during a headache, whatever specifically works for them. One of my patients ended up in an inpatient setting, and it was an inpatient headache treatment setting, and after the whole 2 weeks that he was there, everybody had that blue ice or blue gel or headache gel, everybody was walking around with it. So whatever works.